Sir, we are live now. We can start, sir.
Okay. Good evening. Namaste. Warm welcome to the unique webinar of Indian Orthopaedic Association and India. The topic of this webinar is violence against doctor, how to prevent and how to respond. First of all, I should like to give you a brief information about why this topic is important, why it is relevant in the present scenario. I will give you the brief reason for that. We all enter into the medical field with the hope that we will give name, fame, reputation, popularity, status, as well as money. Most of us get this, but some of us over and above that get something more, unwanted gift of the medical profession. And that gift is the verbal abuse or physical assault, or sometimes they become the victim of vandalism. And this is really very traumatic psychologically. Number of such incidents are increasing day by day, and it has become a big problem for the whole medical fraternity, not only the orthopedic surgeons, but for the whole medical fraternity. So with this, we realized that we got the request from a lot of colleagues, not only orthopedic surgeons, but from the other field like anesthesia and the surgery, that do something on this topic, because we really need to understand how to prevent and how to avoid. So at this stage, I shall like to thank the President of Indian Orthopaedic Association and the Secretary of Indian Orthopaedic Association to take a lead and to give us freedom to carry out this webinar. I also like to thank India, a non-profit but for-purpose organization in USA, which is working for the well-being of healthcare professionals all over the world. They have done extensive work in India during the COVID time to improve the well-being of physicians across India. So before I give you what we are going to discuss, these are the topics which we are going to discuss in the webinar. We are going to talk about the causes, what actually triggers the process, what are the predisposing factors, and what are the fueling factors. The most important thing is, like, we need to understand that it has a serious effects on the doctors. And then we will discuss the three important points, how to prevent it primarily so that it does not take place, how to respond or how to act when it takes place or when it is taking place. And the third and the most important is how to revive from that or how to bounce back from this process, because it's really psychologically traumatic. A lot of people, they say that we want to go for suicide or we want to leave the medical practice. So these are the serious effects and we can definitely prevent them, and we are going to discuss about them also. First of all, let us tell me about the format of this session. This webinar is not in the form of lectures. We are not going to have lectures or didactic talks. What we are going to have is an interaction. And we have selected few important questions which we are going to discuss in the session. In addition to that, if you have any question which you feel that we are not able to answer in the session, please WhatsApp your question on the mobile number 9036 251570. I repeat again, 9036251570. You can send your questions by WhatsApp or by text message on this number, and we will definitely try to include these questions in our session. We are really fortunate to have experts on the topic with us, and each expert has its own specialty, and we are going to take advantage of their knowledge and expertise. We have Deborah Horowitz from USA, John Chaldevon, he's again from USA, and two experts from India, Neeraj Nagpal and Dr. Narayan Karna. Let me give you some brief idea about their expertise. Deborah Horowitz is a clinical social worker Over and above that, she's an excellent trainer and facilitators. She's a creator of Let's Start a Revolution, a program which is for the well-being of doctors. She's also very enthusiastic about a program called FAST. The FAST is basically first aid support team. When such violence takes place, what we need to do, that she's training across USA. And she has done an extensive research on violence, not only the medical violence, but in other field of the sociology also. The other expert, John Chardevon, is a psychiatrist. He is a medical director at Bright Heart Health Foundation, and he has worked extensively for the well-being of healthcare professionals. He is in a leadership and management position, and he is very well connected with India because his mother is from Rajasthan. The third eminent speaker is Dr. Neeraj Nagpal. He is gastroenterologist from Chandigarh. And you will be wondering that what a gastroenterologist is going to do in this orthopedic webinar. But he has an expertise and he's a convener of a medical legal action group, which is helping healthcare professionals across the field. When such cases takes place, he helped them to overcome the challenges. He is an activist working in support of healthcare professionals. He has written many textbook chapters and journal articles on the topic. And he has traveled extensively across India and he has given a lecture in more than 50 cities. The another expert is from the orthopedic fraternity, and Dr. Narayan Karna is an orthopedic surgeon from Pune. He is a chairman of legal committee of Indian Orthopaedic Association. He is a secretary of Maharashtra Orthopaedic Association, past president of Pune Orthopedic Society, and active member at Indian Medical Association. So again, all of them have a specialty and we are going to take advantage of their knowledge in this webinar. At the end, if you want to share your feedback, how do you feel, how we can make it better, please share your feedback on ganjwala@gmail.com or to the president or the secretary of Indian Orthopaedic Association. So with that, I stop sharing my presentation and I request our president, Dr. Sivasankar, to say a few words about the topic and about the webinar. Over to you, sir. Thank you.
Thank you very much, Dhiren Bhai. Good morning, Deborah, and good morning, John, and welcome for this webinar. Good evening, Dr. Neeraj Nagpal. Good evening, Dr. Karni. Good evening, all the listeners from across the globe who are live at present. I would like to thank Dr. Dhiren Ganjwala for taking lead. And this is a very important topic. All of us as doctors at some point of the time or the other have gone through this violence against us, either in a subtle form, as Dr. Dhiren Bhai said, by abuse, or in a great demoralizing way by beating the doctors, which we see every day, some part of India happening in spite of the strict law we have. Unfortunately, very few people have been prosecuted and given the whatever the imprisonment or the fine they have supposed to give. I must thank Dr. Neeraj Nagpal, who is taking a lead, and he has filed so many PILs, and probably all these laws are seeing the light of the day only because of his effort and his group's effort, which they are doing day in and day out. Friends, as Dr. Dhiren Ganjwala sir has said, this is just a beginning. This is an introductory webinar we have today. If you all like, and if you all feel that we should continue, we'll have few more webinars in the series. So don't forget to give us the feedback either to Dr. Dhiren Ganjwala at gmail.com or either to the President or Secretary of Indian Orthopaedic Association. Thank you very much. Thank you for having me here. Thank you. Over to you, Dhiren Bhai.
Yeah, thank you, sir, for your excellent comments and encouragement. I really appreciate, like from the beginning, day one, you are constantly encouraging us to go for this webinar. And it's really like warm feeling to have a strong leader, supporting leader with us. So thank you very much, sir, for that. So now we start our interaction. And the first question I would like to ask to Dr. Neeraj Nagpal. Dr. Nagpal, you must have seen a lot of such incidents happening to various colleagues. So what are the triggering factors, or actually what are the incidents which actually cause this violence? So can you elaborate something on that?
Thank you, Dr. Dhiren, for giving me the opportunity to be here today. Let me first of all break the myth which is there in most people's mind that it is the cost of treatment or it is the excessive billing which leads to violence. This is something I want expelled from people's minds, because 60 to 70% of the violence against doctors in India occurs in government institutions, in public sector hospitals, where cost of treatment is not an issue. It may, whatever less cost is there, it may still be difficult for a person to bear that. That is a separate issue altogether. But the propaganda that cost of treatment and the doctors fleecing and the hospitals making people bankrupt, this is all a propaganda which is initiated by people with vested interests. I don't want to waste your time into that. But if you ask me, one of the most important things why and when these incidents occur, the reason is because people have been fed this, that health is a fundamental right in India. By fundamental right, they understand, or people understand, that when I fall sick, it is the state's responsibility to take care of me. And the state does not invest in healthcare. Because the state does not invest in healthcare, there is prolonged waiting. There are 2 to 3 patients lying on a single bed in public sector hospitals. There is filth. There is lack of civic amenities. There is very poor sanitation. And to the extent that in a hospital, this is Safdarjung Hospital, Delhi, 10,000 OPD patients come there every day. And when this report was filed in Times of India, there were only 20 stretchers in the whole hospital. And people with fracture and with the legs in plaster had to drag themselves up the stairs to reach the OPD. With these kind of resources, there is a problem, and there is obviously anger at this kind of facilities. And when these facilities are not provided by public sector hospitals, people have to turn to private sector, and they do not have the resources to pay for the services, which anyway, if we compare worldwide, are probably one of the lowest across the world. But the thing is, we do not prepare for this out-of-pocket expenditure, either from the government side or from the public side. We have a tendency, we will save for everything else except for our healthcare in old age or our healthcare needs of the family. So this is one of the main issues which arises. Second is, in event of a death, or in event of a complication, we as doctors, we as healthcare providers have very poor communication skills. The way we communicate a bad news to a patient party decides our fate in the next few hours or minutes on whether violence is going to occur or not. And unfortunately, communication skills is not taught to doctors in their MBBS courses. We simply complete our courses. After that, we are shoved into the deep end of the pool. Either you sink or you swim. A person who has never treated a single person, he is asked to declare death at 12 o'clock at night with 12 relatives standing on your head. And they are the ones who are going to bash you when you don't tell them properly of what you have done. You have no knowledge. The third problem here is, in government sector in India, we assume taking a sample to the laboratory is to be done by the relative. The doctor will come and order some things, and a slip will be cut, and the patient's relative is to go down to the chemist shop and bring the medicines up. effectively to this extent that if a serious patient does not have 3 or 4 relatives with him, you can as well issue a death certificate when the person enters the emergency. Now, when you are expecting these 4 or 5 relatives to be there round the clock in the hospital with the patient running around for various things, when the patient dies, obviously there is a sense of anger. Now, this is something which Westerners will not realize, because one of the first answers I get when I discuss this is you should restrict the entry of relatives in the hospital. Now, how can we restrict the entry of relatives in the hospital when the services provided to the patient are provided by the relatives? It is not our hospital staff which is providing them. So these are the issues which come at this time. And I mean, I can go on and on regarding this thing, but the fact remains, poor communication skills, poor spending by the government, heightened expectations. Yes, death is a time when angers are there, emotional outbursts are there, and if it is not communicated in a proper fashion, yes, it aggravates the situation. But as I said, overbilling or cost of billing, cost of the treatment, in my mind, that is not the primary factor which leads to violence in hospitals in India.
Okay, thank you, Dr. Nagpal, for clarifying that excessive billing or overbilling is not the cause in most of the cases. Yeah, that's the first thing which we need to understand. The second, what you rightly pointed out is the poor communication, particularly at the time of death, is probably the first thing which we need to learn if we want to avoid it. And you have rightly given a background that in India, when we become an orthopedic surgeon, we are taught how to do a nailing, how to do a replacement. But we are never taught during our undergraduate or postgraduate training how to communicate with patient. So complications and the death, these are the two things which we are not taught how to communicate. And yes, if we want to improve this, then we really need to do something on that. So moving from that, we go to the next and the most important thing about the effect. As we saw that it could be a just verbal abuse with the patient's relative, or sometimes it could be the physical assault, which we have seen many videos circulating in the social media, or sometimes it is just a vandalism by the group of people. Ultimately, this has a bad effect on the psychology of doctors. So we will try to understand 3 aspects. The first, what is the effect of this incidence on the psychology of patient? So we will ask Dr. John to tell us about that. Then we will understand what is the effect of this on the practice. How does it affect the practice? And the third thing is like, what is the social effect of this problem on the doctors? So now I request Dr. John to tell us about what is the psychological effect of such incidents on the doctors.
Thank you, Dr. Duran. Excellent question. And I first would like to thank the Indian Orthopaedic Association and INDIR for hosting this and for inviting me to participate. This is an important topic. And to specifically discuss first the psychological impacts, as was briefly mentioned earlier, there are different ways that this can impact the individual doctors and other healthcare professionals. There are the emotional consequences, and these include anxiety, depression, irritability, the suicidal thoughts as described earlier. There can be profound grief, both about the sense of self, loss about the idea of I'm a kind of person who helps people and why are these kinds of assaults happening towards me, grief if there's actual loss of life. And there's also could be disbelief or shock about this happening. The person might feel less loving and warm feelings towards loved ones. There can be troubles with sleep, intrusive thoughts or images about what happened, nightmares about what happened, and post-traumatic stress disorder is one possible consequence as well. There can be behavioral changes. The person might become more socially withdrawn, may lay in bed a lot more, not really motivated, might start missing work, and might turn to unhealthy substance use like alcohol. There can be changes in identity, doubts about the self and abilities as a doctor and maybe broadly as a person. There can be thoughts to change the job or career. And there can be a very profound dread of even going back to or waking up in the morning and just dreading going back to the work, getting back to the hospital. There can be cognitive effects that can impact difficulty with concentration, memory impairments, difficulties in decision-making. And then I just want to highlight that violence and trauma are very interconnected. Hurt people hurt other people. And what I mean is that people who have been hurt in various ways, emotionally, physically, throughout their lives, they have so much shame, they have trouble managing emotions, quick to anger. So then they might be sensitive to feeling humiliated, ashamed, ridiculed, rejected. And so because of that, they might be more likely to lose control and react aggressively. And so one way of conceptualizing this is that if you assume that people have experienced these kind of traumas in their lives, and if you approach all patients like that you might start to take a different approach in communication, like Dr. Nagpal described, that the lack of training about communication, lack of considering how to understand the patient's perspective as a person, aside from the actual diagnosis, that could be helpful, and that will be discussed a little bit more in detail later. In terms of the concept of burnout, burnout is more a chronic process where an individual doctor might feel ineffectual and incompetent while working within a system that doesn't work. And like Dr. Nagpal described, if in the government hospitals where people are overworked, underpaid, lack of resources, lack of staff, the family members are actually the ones administering the actual medicines or getting the medicines, that within this kind of system, physical, emotional, mental exhaustion can arise. And then it can also result in the doctors feeling disillusionment, not finding meaning or gratification in the work. It can reduce the sense of accomplishment, and people become more skeptical, become more blaming of the system, of their colleagues, of the patients. There's a loss of compassion. There can be a increased distrust amongst people, where they're questioning why am I doing what I'm doing? Does it make a difference? Managers and supervisors, leadership might not trust the staff, so there might be more micromanaging of the staff. There's a decreased sense of social safety. And then burnout can also manifest as frequent physical symptoms: colds, headaches, fatigue, a reduced tolerance to pain, difficulty with tolerating prolonged patient contacts, lower resilience, moodiness, crying more, and then less empathy and detachment from patients because they're seen as too draining emotionally. And thinking more specifically about the second victim syndrome, that's the idea when the healthcare provider, the doctor, is involved in some kind of unanticipated adverse event, serious medical error, could be serious patient injury, patient death, and that can be, the doctor becomes victimized in the sense that the provider is traumatized by that event, and then oftentimes they feel responsible for the patient outcome. They can feel shame, anger, failure, inadequacy, a loss of confidence, and potentially post-traumatic stress disorder. They feel like they failed the patient, they failed the family, they failed themselves as the good doctors that they see themselves as. They doubt their clinical knowledge and skills. And this is related to a concept called moral injury. Moral injury occurs during a traumatic or an unusually stressful situation when people may act or they might not act in ways that contradict deeply held moral values. This can also occur when witnessing certain types of events, and this can manifest as feeling betrayed by leadership and others in positions of power that resulted in these adverse outcomes. So the person feels like there was some kind of wrongdoing that occurred by themselves or someone else, or they didn't act in a way that they should have, that crossed the line with respect to their moral beliefs. Guilt, they should have done better. Shame, that whole person, there's something wrong with them as a person, total failure, disgust with those actions, anger about the situation or themselves, the people around them. And another important component is there's a difficulty with self-forgiveness. They can't forgive themselves or find compassion for themselves. And that can result in self-sabotaging behaviors because they feel like they don't deserve to feel better. They don't deserve to start to work on themselves to not feel these suffering symptoms, that they deserve to feel this suffering as a punishment for their transgressions. So I'll stop there. Thank you.
Yeah, John, what you said is absolutely right. It's a wide spectrum. The problem of all these psychological symptoms are that we cannot see them from outside. And most of us, they feel that what we can't see does not exist. So as an orthopedic surgeon or like any other people who is not having an insight about psychological aspect, they will think that all this is basically theoretical thing and this does not happen. But it's not so. What you said is really a serious effect. But there are few effects which we can really see. And I would like to ask Dr. Karna about that. What we see the effect on the practice, like how the practice of that particular doctor changes after such incidents.
Well, thanks, Dr. Dhiren. In India, the practice is divided into three main categories. As Dr. Neeraj Nagpal has also said, that it is either the corporate hospitals or the general government hospitals, but the 85% of the medical care is given by the small and medium nursing homes, which are owned by either a single doctor or the small group of doctors. As far as effects of this vandalism or the violence on the practice is concerned, the practice of the institutions doesn't affect much, because most of the patients who go to general hospital are from the lower class, and they have to go to that general hospital at any cost because they cannot afford the private hospitals. And the patients who go to the corporate hospital, they are from elite class and from higher class. And so yeah, even whatever happens there, the patients are going to go there. So as far as the hospital practice is concerned, there is not much effect of this. But the individuals who are working in that hospitals, they can have some impact. And this episode of this workplace violence has a wide-ranging impact. Even though there is a backup of the institutions for these doctors, the negative effect of these incidences is not just limited to the doctor's physical and psychological well-being, as John has said, but it translates to the other issues such as reduced job performance, increased burnout, and mental exhaustion, as well as emotional distress. So they either take the leave from the work for a long time, or they don't appear at all to the work for quite a long time. And this ultimately can affect the quality of the patient care, which collectively can impact the entire health system, especially in the general hospitals. Now, what is about the private nursing homes? This is one sector we suffer a lot, as there is no protection or the back support from anybody like a corporate or general hospital. He's all alone there. So the impact is very heavy for the private practitioner. He's defamed to a great extent, and his practice mainly depends upon his stature or his social value in the society. So he suffers a great financial loss as well as social loss, because he's known as a person, and he just can't show his face to the other people, and there is a great psychological impact because of this. Rather, the doctor who is public spirited in the initial phases, he wants to do something for the society, he wants to do something for the patient's health, he gets completely discouraged after this, because there are doctors who have spent their life almost 30-40 years for the social service, and they're they are thrashed like anything just for a small mistake in a village. So that is one of the main aspect. So with slightest complication or even an adverse drug reaction, he's scared now that if he gets something, he immediately shifts the patient to the higher centers. He has to do so many investigations which would not have done in the normal circumstances, because something comes up, the doctor is held responsible for that. But this has got effect not only on the finance of the doctor, but also on the middle and the lower class, because they have to go for many investigations, as well as they have to go for the higher centers. So the doctors also, they refrain from performing any complicated procedures which might have unfavorable outcome, because sometimes in orthopedic, the patient generally doesn't die, but there are unfavorable outcomes and the doctor is held responsible. And lately, most of the nursing home doctors are not doing any high-risk surgery. I am also in practice for 36 years, but now I am taking all my high-risk patients to the institutions and operating them there, because there is chance that it can lead to the death. There are certain doctors I have seen, they have taken premature retirement. My elder sister has taken premature retirement because of this. Rather, some have changed their profession. My own son, I had 2 hospitals, but my own son, after MBBS, has left medical profession and he had gone into business, because being in medical legal profession, he sees every day I tackle 2 or 3 cases, and he has seen such a scenario. My own 2 nephews, one had gone to US and one had gone to UK, because they are leaving the country because they think India doesn't deserve their talent anymore. Now, for the aspiring doctors also, their parents have become so much apprehensive that they are not letting their children to take this profession. And even the certain talented students who are taken for medical has left that and had gone to the even civil services. And because of this brain drain, what I feel that the effect of this will be felt by society as well, the whole healthcare system, not now, but will be felt after 20 to 25 years, when there won't be any talented person on this. There won't be any talented person in the medical field. That's what I feel, that the effect of the practice will not only affect the doctors, but will affect the society also in general.
Yes, that's very right. And I really appreciate the way you explain the whole problem, that it's not only the individual doctor who is affected, but it's the whole society, the whole medical practice is affected because of one such incident. And yes, it has a lot of effect on the practice also. You try to become very safe. You want to like over investigate the patient, and that ultimately increase the cost of treatment. Now, Dr. Nagpal, I should like to ask you, like, what have you seen the social effect of this, the effect on the social relation with the family members? So from your experience, can you tell us more about what happens to such doctors?
Before I answer your question, Dr. Karna raised the issue that corporate hospitals practice does not suffer. Let me contradict that. 2001, Singhania Hospital, Thane. This used to be one of the few first corporate hospitals. It was trashed, and in 2001, the losses were calculated to be around 10 crore. I mean, 10 crore, this will have to be converted for our US guests. But effectively, this corporate hospital was trashed, absolutely, and it was just closed down after that. So even corporate hospitals, there was a Shiv Sena leader who had died over there. I'm sure Dr. Karna knows about this case. So the issue is, even corporate hospitals practices can suffer, and it is not as if they are immune. The second thing is, we always, I mean, John has raised the issue of second victim syndrome. But we somehow always associate an incident of violence and second victim syndrome, where I disagree. The reason I disagree is violence leads to post-traumatic stress disorder. Second victim syndrome implies that the doctor has committed an error, and that is what he is reeling from. So I may be wrong, I'm not a psychiatrist, but I strongly feel that when we are talking violence, what is associated with violence psychologically for the doctors is PTSD rather than a second victim syndrome, which is more related with errors which doctors do, because violence in India at least can occur without any error or mistake on a doctor's part. Now, coming to the question of my experience regarding social effects. Well, I had a friend, again an orthopedic surgeon in Chandigarh. His son was studying in a school. This was one of the premier schools in the city. And his son's classmate, and everybody was playing football, and one of his son's classmates fell down and he broke his femur. Now, he was brought to the orthopedic surgeon because he was father of the classmate. He reduced the fracture and he applied a cast. This led to a compartment syndrome kind of a situation, and later gangrene happened and later amputation had to be done. Now the boy who was working in the school was made to stand in the school assembly. We are talking of the social effects. Look at the ostracization which happened for us, for the son of the orthopedic surgeon, to the extent he had to leave school, to the extent that the doctor had to shift after nearly 10-12 years of successful orthopedic practice in Chandigarh. He left the country, he went to Australia, and they had to leave everything behind. So when we talk of social effects, The person doesn't psychologically, of course, he is scarred. He doesn't want, because anywhere he goes, any marriage party he goes, anywhere he goes, even in his practice, his patients will ask him, or people known to him will come and ask him. And it is assumed that the doctor, I mean, this is a very common assumption that there must have been a mistake. I mean, death, after all, if sick people are not going to die, are healthy people expected to die? And where are sick people going to die? They are going to die in hospitals. So what is so strange? But sometimes certain political groups, or I have faced this, local level politicians, they unnecessarily instigate a crowd on death of a low level leader or somebody in a hospital. That death may have nothing to do with an error. That death may be because of an accident. The person has not been successful to revive the gentleman, but that does not mean there is an error in that case. So, I mean, these are very strong feelings which I have, but I would like to be corrected if I am wrong about the second victim syndrome versus the PTSD which I have raised.
What you said is absolutely right, and we really don't try to go into the controversy of the terminology, whether it's post-traumatic disorders or the second victim syndrome. But what you said is very correct, that it has a lot effect on the person's practice and on the social side. And it was really disheartening to know about the incidents which you mentioned about the Chandigarh orthopedic surgeon. That's really bad, that his son has to suffer for the incidents which taken place at his father's hospital. And even his father was also not responsible.
Sir, believe me, there were 45 front page news articles in Chandigarh repeatedly over a period of 6 or 7 months. I had to make a complaint to Press Trust of India to stop the reporters from Times of India to be publishing this kind of inflammatory news articles on the front page repeatedly.
Oh, that's really, I appreciate your proactive action against all this. So now let's move further and let us try to understand the predisposing factors which takes place or which are responsible for this. And I will like to start first on our side, that what as a doctor, we need to understand that what is wrong with us. Already we discussed that there is a problem in the communication and we are lacking communication skill. But over and above that, there must be some other reasons. So I asked Deborah to tell us about what as a doctor we can change our skills or we can change our approach to the patient that helps in prevention of this problem. Yeah.
Thank you very much. Thank you, the Indian Orthopaedic Association and India, for having me today. As we've been talking about, violence is a very complex issue. It has public health components to it, institutional, instructional mechanisms that are all impinging then on the doctors and the practices. And violence is an interactive process that can be interrupted. And it can be interrupted if we're able to see ahead of time and in the moment, what are the things that could potentially lead to an aggressive event. And these things are both verbal and nonverbal. What we often forget is that 55% of the way that we communicate is through body language, and 38% is through tone of voice. And so we spend 99.9% of our time focusing on just the language, where that's only 7% of really how we communicate. We really need to talk about de-escalation as running with the brain science. That one of the things that we are working to do in an escalation is to calm that part of the brain that has the fight, flight, freeze, or appease mechanism happen. And that's a human component. That component doesn't know that you're wearing a label that says doctor or that that the other label says patient. What it says is a human. And given the right set of conditions, we all could be potentially violent. And so talking about trauma as it impacts us psychologically, physically, but also in the moment when you as a physician are having your adrenaline dump and are feeling backed into a corner and feel as if you want to fight, flight, or freeze. There are strategies where we can then decide what to say, when to say it. And there's an escalation continuum that goes from very simple questioning The patient has a need. They ask you a question, all the way up to and including the verbal abuse, the big release of emotional information explorer, and also then having the physical response, because people will escalate emotionally before they ever escalate physically. And so we have a lot of opportunity ahead of time in that moment to do things differently. How we stand, whether we use we language as opposed to I, whether we're standing next to and camaraderie with our patients, or whether we're squaring off toe to toe, has a lot to do with the way that we're communicating intent. And I don't think, and it's true here in the United States as well, that medical and healthcare professionals are often given that training in their studies. This is something that comes along with years of practice and research, but it can be learned. And that's what's wonderful, that compassion and empathy and how to foster pride again in our physicians, in our healthcare workers, and in our patients feeling self-efficacy will decrease the likelihood that there will be a physical escalation or a vandalism, et cetera. Sometimes it is because we are in that fight, flight, or freeze mode ourselves that we misattribute motivations, right? We get into the us and them place. And really, it's all us. And if we can stay in the all us, then we can de-escalate a situation very successfully. And it doesn't have to take a lot of time. That's what's nice about some of these things. You really are having heart-to-heart communication and less head-to-head communication at that point.
Okay, thank you, Deborah. Like it's rightly said in our, like my Gujarati language, that you cannot clap without two hands. So the same thing happens here also, that there are two parties, the doctors and the patients. So what you said about is about the doctors, that we need to understand the patient's emotions and we need to respond similarly. And definitely we can do something when the escalation is taking place. We can definitely take actions to prevent escalating the situation. But before we come to that, about the prevention part, I would like to ask Dr. Karna, what do you think that how many or what is the percentage of approximate percentage the patient's factor are responsible for this? It's not only like one-sided. There is always two people in the any fight. So there has to be something wrong with the other party also. So exactly. What do you think?
Exactly. That's what I said. Though it is a multifactorial, this particular situation arises because of many factors. In India, the situation is different. Okay, as we had said in the beginning also, that doctors are not much trained to deal with the situations like this in their curriculum. But the kind of the society here, especially those who resort to the violence as such, that is totally different. So there is a much small window between the verbal abuse and the physical abuse here in that particular type class. So these factors which are related basically to the patients, relatives, as well as the politicians and the goons, which is far more common in India as compared to the Western countries. The hospital factor and the doctor's factor relatively are not that serious that will incite the violence. But then it turns into the violence because the patients and relatives mainly in this particular are the lower class and their nature is of a conflicting. Even if they come on the road, they start conflicting immediately. That depends upon their social status as their culture. That is like that. Their understanding level is also quite low, and their analytical ability, exactly how much the wrong doctor has done or what exactly is the situation, you know, they are more like a reflex one. As Dr. Nagpal said, that one of the whole corporate hospital was completely vandalized, completely. And even the aeroplane of that owner was there, which was also damaged. He had suffered loss of around 20 years ago to the tune of 20 crore. So he has to shut down the whole hospital. It was not that the only practice has stopped. He had to shut down because even that party was such a kind that the cars in the 1 kilometer area were damaged. That particular case. So these that is a sort of reflex actions of this particular class. Then in India, the great role has been done by the media, as again Dr. Nagpal said about this Haryana case, that the social media, the print media, the TV channels media, these are TRP seeking medias, and they're masala hungry. Especially one famous actor, Dr. Amir Khan, he has started one serial, and that has prejudiced the patients very much against the doctor. That was the beginning. Because here in India, the heroes are considered as a god. There are temples of certain heroines there in India. That's when they are saying something, they are projected doctors and the medical profession in such a way that they are greedy and the luteras. Then, as I said, patient and visitor also has got nuisance-making tendencies. So even with a certain reason, either the patient is aggrieved or the dissatisfied or irritated, he gets immediately lower down. Means there are certain expectations are not filled. As I said, there is some problem in the bills. No, if there is a wide difference, the bill which is told in the beginning something different, and the bill which told later on is different, then they start abusing. Then unexpected complication or the sudden death, the situation becomes violent within few minutes. So sometimes the relatives which come there, they are under the influence of either the alcohol and rarely of the drugs. And unless put otherwise, especially after 8 p.m., when such kind of class comes to us, we assume that they are under influence of the alcohol, and then they come in the mob. This is about part of the patient and relatives. The second part about the politicians, we call them as pseudo politicians. Because the real top class politicians, they never entertain into this. But the lower cadre of the politicians, they are like this. They are basically opportunistic, greedy, and the ruthless. They want a cheap publicity, and they will go to any extent to please their voters and to show how much they are doing that for allegedly poor patient. And they have got a prejudice or some previous grudge, because this happens in nursing homes, that they might have come for some other reason and they are not treated as a VVIP and their ego is hurt. Then they keep that prejudice in their mind. Especially they call every now and then that reduce the bill of this particular patient, even if that patient is not from their constituency. And if that is not accepted, or the hospital doesn't bend to their undue demands, or even sometimes they have got certain mandals, mandals, and the programs or events are there, and if the doctor doesn't give the contribution, that prejudice is kept in the mind, and they try to find out some excuse to harass the soft target. They find every opportunity to vent their all previous grudges, and sometimes they deliberately change the perception about the doctor among the patients. And these are the ones who control police, media, as well as the society. Sometimes they go to any extent to just for sake of extortion. And I have seen certain politicians who take money from the doctors and give peanuts to the patient and take most of the money they keep with them. So that has become one of sort of an extortion racket for these politicians. So what we tell all the doctors, that especially for all such, there are certain parties which are well known in Maharashtra who are known for the vandalism, that keep good relations of such politicians so that they won't harass you. The third part is about the goon related. Now the goons also are semi-political, because they cannot survive without political support, and politicians use them their own purpose. But the difference between these goons are having basic personality of the arrogance and the confrontation, and they can make issue out of nothing. Generally, these people are constantly under the influence of the alcohol or the drugs, and they trigger the mob psychology, and in the fit of the rage, the mob doesn't think what they are doing, and there is a lot of destruction as well as damage to the doctors. And they don't bother about the consequences also, because at the back of mind, they know that their politicians are going to help them, because their main aim is to make a rada. There is a word which is there commonly used, that is a commotion. And sometimes they do it just for ego purpose or the mental satisfaction. As if a truck driver is beaten in the case of the road accidents, they don't see who is actually at the fault. Similarly, once they get a chance, they beat the doctors. So that is psychology of the goons also in this country. So in this country, the window between the verbal abuse and the physical abuse is so low that one can't say that at what extent suddenly these things will happen, especially if it is backed by the politicians or the goons.
Okay, thank you, Dr. Karna. Like, I am sure that our foreign faculty must be really surprised to listen to what Dr. Karna said. But yes, what he said is actually the fact. And these are the problems which are really difficult to deal with and solve. So probably I don't know how we are going to offer a solution, but these are really difficult to solve problems. Dr. Nagpal, would you like to add anything to what Dr. Karna said?
Sir, absolutely right. He has hit the nail on the head. Basically, we have to follow the hypothesis of broken window hypothesis, as it is called. John will be with me on this. Broken window hypothesis says that somebody throws a stone at your window. It is a minor crime. If you start ignoring it, he gets encouraged and he graduates to a bigger crime. So you have to check this at the level where this doesn't become a major issue. Why we are not, I mean, despite the Singhania hospital case, and that was one of the first cases of major violence in our country. Despite that, when I see the bulk of cases, corporate hospitals are not targeted. Mostly corporate hospitals are not targeted. There are very, very few incidences in corporate hospitals. Majority are occurring in government hospitals, in small and medium healthcare establishments. These are the places which are targeted. And they happen here because people think they can indulge in violence and get away with it. There is no deterrent. Rules, laws are not enforced. We have to be proactively following the broken window hypothesis. And a patient's relative speaks in a higher tone, action has to be taken at that step. We cannot wait for a mob to collect, because today it is the WhatsApp generation. Please imagine, I mean, I'm sure John will not have encountered this situation in US, that there are 400 people who have come and assaulted a hospital. They have done vandalism there. And in Southeast Asia, this is rampant. But how do you communicate? I have to give a lecture to 200 doctors. I know how much effort it takes me to collect those 200. But these 200, 300, 400 people attacking a hospital, this happens within minutes. These are organized. Even in India, in China, you have this Li Now phenomena where there are groups which will come into the picture if there is death and there is a hospital bill pending. They will come, they will negotiate with the hospital, they will do some demonstrations, they will throw some stones and negotiate with the administration to get the bill refunded or get the bill waived off, and they will charge a percentage from the patient's relatives. This is a Li Now phenomena which is there in China. In India, we are also having this. Calcutta, we had a recent case where a family of 5, they were involved in repeated incidents of violence across the city in different hospitals. So their case went for bail to High Court, and the High Court refused because the police gave evidence. Look at it, how can one family of these members be involved in incidents of violence against so many hospitals? They had made it a profession. And unfortunately, as Dr. Karna has said, in India, politics, the way it is progressing, the politicians depend on what I call contractors, subcontractors. Now, these subcontractors, their only purpose is to gather a crowd of 200, 300, 400 people at the call of the local leader. What is the reason? What is the reasoning? Absolutely, that is of no concern. It is simply to gather a crowd. And this is very organized. Number 2, one of the major things we are facing, I'm just going to skip to the question direct which you gave me. One of the problems we are facing in India is we have shifted from the system of medical education we used to have 20, 30 years ago to something called NEET, and it is all now exam-based and multiple choice question-based. So what is happening is, in our internship, in our generation, we saw our seniors communicate with the patients, and we learned from that. Today, an average intern is not attending internship at all. He is going to coaching classes to learn how to score good marks in the NEET PG exam. So with internship failing totally, effectively they do not have the opportunity to see and learn. Internship was the place most of us learned how to deal with patients by seeing our immediate seniors, their immediate seniors, how they communicated with the patient. We used to learn and we used to imbibe that. Unfortunately, with this multiple choice questions becoming the primacy, the whole focus now is on these coaching classes which teach medical graduates how to clear these exams. So I have very strong views. I know somebody will be probably disagreeing with me, but this is one of the main reasons. And of course, the general hospitals I've already covered. One of the reasons is we allow so many relatives, we need so many relatives in general hospitals that we have made them to run around for 10, 15 days, getting everything from a glass of water to a syringe. And now, when after all that effort, if the patient still dies, obviously they have a anger which they try to vent out.
Okay, thank you, Dr. Nagpal. Now we go to the most important point of our webinar, and that is about the de-escalation technique. When the incident is taking place, when the process is gradually going up, how we can respond to the situation that we're going to learn, because the de-escalation is a process or the terminology which I came to know about only recently, and I'm really curious to learn about this. And for that, I should like to request Deborah, who is an expert of this technique, because she runs a 10-hour long workshop on this topic. So Deborah, what are your suggestions to the doctors? What we can do to de-escalate the situation?
So for doctors, there are a lot of ways in which you can change the way you interact in that whole process. Everything from the way that you stand, crossing your arms when somebody says that I'm closed, to whatever you have to say, leaving your palms open, standing a reasonable different distance away. One of the things that I see a lot when there's an escalation that happens is that one or the other party then becomes defensive. As soon as there is a challenging question, which implies that somebody has been feeling shame, humiliation, rejection, or ridicule, which are the 4 big ones when leading to an escalation, beyond moving from the first question of I have a specific need, like how long do I have to wait? If you know that answer, then be short, direct, and accurate with that. If you don't answer that, or you can't answer that, you may get a challenging question, which will start off things like, how dare you? And who do you think you are? And sometimes what I hear back from our healthcare providers is, I'm so-and-so, and I have this many degrees, and that is a defensive posture that seeks to escalate, not de-escalate. At that point, you want to restate whatever your request was and offer options. I invite the doctors to think about using the SCARF model. It's SCARF. Status, certainty, autonomy, relatedness, and fairness. The larger the gap in status, the least amount of certainty, the fewer choices and autonomy, the difficulties with interpersonal relatedness, and the fairness of the decision are going to need to guide you into how to respond. Because when somebody is escalating and their voice is getting louder and they are starting to yell, we often want to give them a long-winded explanation to get them to calm down. Or we even say things, calm down, calm down, calm down. What that does is engender more shame in that individual. They already know that they're losing control. So part of that response is, I can see you're really distressed. Tell me how I can help you. 5 words or less at that point. And oftentimes we get into these stances of they don't understand, they're not listening, when the brain science tells us at that point that their auditory processing isn't online, that their focus is narrow. 5 words or less. Best ones, how may I help you? Tell me more. And that can go all the way up into a big release of information and also emotion. And there's certain language that doctors need to be aware of, that when these terms come at you, and in America there are a lot of expletives that relate and make a person down to their base essence, that is the time to exit stage left, to get out of the situation. Sometimes we want to hang in there too long when there comes a point when words are no longer appropriate. And there are actually physical disengagement skills. So if somebody goes to hit you or grab your hair or try to choke you, there are skills to get out of those maneuvers. And all of those together can help save a life and de-escalate a situation. The other thing I sort of want to also point out is that we tend to think that people who are watching mob violence are just standing there complicit in it. Oftentimes they are in their own fight, flight, or freeze mode, and they may be shut down entirely as well. And they may not have the skills to de-escalate it either. So we can't assume that other people are going to step in for us without appropriate training. And it takes doctors lots and lots of practice to go against their own fight, flight, or freeze mode. You do this very nicely in a medical crisis, right? When somebody is coding or has an urgent need for surgery, you go right in and you fight against that. This is somewhat similar. You want to, just because somebody else is laying the trap for you to step in it, doesn't mean we have to. We just have to be aware of what we're saying and when. And so there's this whole continuum. And hopefully with the 10-hour program that I'm offering, I can show and share with you all of those skills and have you have time to practice and feel comfortable using them.
Deborah, I have a doubt that these theoretical knowledge about the de-escalation, does it really work when the things are really heating up and when the tempo is really going up on both the sides? Like, we have a tendency to come to our original way of dealing with the people, and we forget completely about the new technique which we have learned from you. So is it really applicable when such incidents take place?
Absolutely. It is absolutely applicable. It's like a muscle that you learn and you can flex it, and repeated use of the muscle, it becomes more automatic. It feels uncomfortable in the beginning. It may feel awkward, but these have been proven, and with a lot of our persons served, a lot of our doctors, and even with the riots that we have had here, these have also been very effective in minimizing the extent of the damage, the trauma, and the pain. But it is a new way of conceptualizing our role in the process.
So that's really hope, the sign of hope for us, because like if we learn and master this technique, probably we can do something to stop the process when it's really going up. So I think I must request you to have more sessions on that so that we really learn about that. So before we come to these skills, I would like to ask Dr. Karna about Dr. Neeraj about the practical ways how we can save ourselves from such situation when the things are going up.
So the most important thing is what you have done before the incident is happening. You have to have a standard operating procedure in place. For the healthcare establishment, it is absolutely mandatory that a standard operating procedure is in place, which is repeatedly ingrained into all the staff members by regular drills. Who will inform other staff members to get them to the place of incident? Who will inform the police? Who will inform the doctor colleagues? Who will videograph the incident? Because when an incident of violence occurs, there is confusion. The doctor most probably, and especially in a small and medium healthcare establishment, will be, he will not be in a position to give orders for these things to happen. And even in a larger hospital, you have situations when especially workers are understaffed. Even when you are having regular SOPs, if there is high worker turnover and the workers who have been trained earlier simply leave and go and join another, and we do not repeatedly do the SOPs training for the workers, then these problems are there. But once an event occurs, it is very important that you need to call others to the side. If you are in a small and medium healthcare establishment, message should go to similar small and medium healthcare establishments in the area so that doctors and other workers can be called to that place. There has to be a system of panic buttons. There has to be a system of securing the furniture which can be used as a weapon to floor or wall. Exit routes should be there wherever possible so that in case a doctor feels threatened, he can exit the room. Provide the employees with a safe room for emergencies, because at times this thing can escalate to a level where personal safety will become more important. And of course, as I said, CCTV monitoring has to be there, and there is no question of avoiding that, but all this has to be done. Basically, when an incident of violence is occurring, your focus should be on containment, isolation of the area where this violence is occurring, and personal safety. These are the issues which have to be kept in mind when actual violence is occurring.
Okay, thank you. John, I think you have also some suggestions about what we can do to prevent such things happening. I understand that probably what you suggest is applicable to the US practice, but do you think that you have something to say on this point?
Thank you for bringing it up. And actually, just like Dr. Nagpal stated, that standard operating procedures, and those are important so people know what to do in that situation. And then I would also add too that being aware of what can be used in terms of the clothes that we wear. Long hair can be pulled. Wearing a tie, you can get choked with it. If you wear some jewelry around the neck, a lanyard, that all of that can be used to choke as weapons. Open-toed shoes, people can step on it and break your toes. So be aware of actually what you're wearing, what's on you, on the desk, that where patients sit. Are there staplers? Is there a landline phone? Can that be picked up and thrown or bashed on the head? So be aware of your office, of your surroundings, and remove out of the ready reach of the patients and the family members anything that could be potentially used as a weapon in order to make sure that that decreases the probability that there's an object that could be used as a weapon. So these are additional considerations.
May I add to that for 1 second? John, you bring up a wonderful point. The 3 A's are something that we talk about here. That when somebody is looking to target you, they're looking for how aware are you of your surroundings? How available are you? How fast can I get to you? What is the likelihood somebody will come and rescue you? And how accessible is there something that's a weapon? And so people who are looking to perpetrate some kind of violence in this way, if you are aware of those things and mitigate those things, you give them less opportunity as well.
Thank you. So we really understood some of the ways by which we can actually control the situation when it's happening. We learn about the preventive ways also. So basically, we need to design our hospital, our consulting room, everything in such a way that we think about this happening in the future. And I must admit that very few doctors have that long-sightedness vision when they start practice. We are so naive when we start practice that probably we don't think about such things about future. So what you really gave is really a good insight for the beginners. When they open their nursing home, they should keep this in mind. So now we come to the most important point, and that is like when the things has really happened, the untoward incidents has taken place. It has really caused a lot of psychological damage to you. What should we do? So now we are coming, or we are moving to the incidents has already taken place. What we should do now? Because we saw from the John's initial comments that there is a lot of psychological things happen inside the mind. And definitely it has a lot of effect on the practice and on the social side also. So the first question is, why should we actually take a psychological support? This is very important in India because we believe that the time is the most important healer. So most of us feel that if you allow the time to pass, most of the psychological injury which has taken place will heal automatically. So I would like to ask you, John, why should the doctor take help of the colleagues, the psychological colleagues? Yeah, please.
Thank you. That's a great question. And a parallel way to think about it is that if there is a spiral fracture in the femur, the time is not going to heal it. It needs to be addressed, and there needs to be a specific intervention. And the same thing with the mind, that when there is severe trauma, as everyone has been describing today, that requires specific interventions to address what's happening to the individual. And from at least the individual perspective, when people have gone through such traumatic experiences, like Dr. Nagpal described the significance of the potential post-traumatic stress disorder and all these other consequences, the person is suffering, the individual suffering and suffering alone, and might feel like no one else can understand, and might feel like this will always be like this, and I can never get better to the way I was or function again. And so these kinds of thoughts, these doubts will also perpetuate the suffering. And as I described earlier, the various emotional, behavioral, cognitive, identity struggles, the moral injury, grief, that these are very painful, and they don't necessarily have to continue. That if a person specifically gets support, and the support might vary, at least if there's support, that can improve. And so the organizations, it would be helpful to create standardized operating procedures in order to be able to address after any kind of incident. These are what this is what we expect. We're gonna make sure everybody addresses these, and then in this process we can determine who will need more in-depth interventions. And actually, like Dr. Karna described earlier, there's also the impact not just on the individual's emotional state. There's the either not showing up to work and missing work, taking a long time off, changing work, moving out of the country, the brain drain on society, less availability of doctors to treat other kinds of patients, and so all of these different factors are also possible. And at the same time, when a person does return to work and is still struggling, that there are worse outcomes for patient care. There can be maybe a little bit more medication errors. There might be more conflict with the patients themselves and more irritability with the patients themselves. And so it's important to acknowledge that it doesn't just impact the individual, it impacts patient care, it impacts society in general as well.
Okay, the quick question to Dr. Karna and Dr. Nagpal, like a lot of colleagues come to you for taking an opinion. Do they really take psychological support while passing through this phase? Do they really take help? Dr. Nagpal, what do you think?
So psychological factors or psychological support is the last thing in North India, at least, which is there in the minds of doctors. Somehow we have this concept that if I am depressed, this is not an illness, I have to get over it myself. An illness is when I have broken a leg. So this is something which needs to be changed. This is obviously because there are many studies that if one person has been involved in one such instance of violence, it is likely that he will be involved in another incident where he may actually have made a mistake or made an error, and he may find himself, this could occur because of his psychological position, or it could also occur because of some other patient feeling if that patient could do it and get away with it, maybe I can also. So this kind of message which goes out can also create a problem.
Yeah, I also support Dr. Nagpal that in India, the doctors they don't get psychologically that much affected that they require some psychiatric support. Then they come out of their own and they are more worried about the further things, that are how much impact there is on their practice and how to
financial they are more concerned about.
Right, because generally the psychiatrist opinion is not required, at least in Indian scenario, what I have seen them. Sometimes what happens that we tell them how to cope up with the situation, how to learn to tackle the situation. As I said, one, that you should have good relations with the local politicians, local police officer, even if somebody calls you, give him concession henceforth, because that we can consider. There is the one called as extortion money in certain terms, even in Mumbai and many other places. The shopkeepers have to give the extortion money, and we can tell them that consider this as a tax of the government or the extortion money, but then that will give you the immunity. But instead of going to the police, rather the police are not that helpful in even the city like Pune also. And that's why the doctors have to learn to cope up with the situation, and they cope up. In India, generally they cope up. Only the highly brilliant doctors, there are two types of doctors. One are highly intellectual doctor who concentrate only on their academics, and the nursing home owners are something different. Nursing home owners are the really business entrepreneurs, and they learn to tackle the situation and they come out of that very well. The only thing we have to tell them that the ABC, how to come out with this particular situation. As I said, understand those things. Try to don't allow the situation to get escalate. And rather, last 20 years, I am telling all those doctors who are coming to me for consultation that you should have a backdoor entry for your nursing home or your clinic, that you can go away when the situation is escalated. At least you can save yourself.
Okay, so basically, there is a difference of opinion between Deborah and John said that we need to take a psychological support. And on the other end, Dr. Karna feel that most of our colleagues, they have a tendency to come out of the shock with passage of time, and they learn this technique automatically. Before that, let's understand that when, yeah, Dr. Nakpal, yeah, please.
I am not saying doctors in India after an event of violence do not require psychological support. They think they do not require. And as a social way of life, we are more concerned with the physical, with the practical things. Whereas, as I have already mentioned, if you have undergone an incident of violence, you are more likely to undergo a second incident of maybe an adverse event in the hospital, or maybe a patient filing a suit against you for compensation, or maybe even again a violence. So the point is, psychological part in India, we do not, as a society, or to talk of doctors only, even as a society, we tend to keep it under wraps. We do not tend to discuss. We do not open up as easily as people abroad. And this is true for professionals as well as non-professionals.
Okay, so exactly that is what I am trying to ask a question. That yes, we are reluctant to take the help. So Deborah, can you explain us like when we should take help? What are the symptoms? When we recognize such symptoms, we should be ready to take help. So can you clarify on this side?
So very often the first ones are physiological. If your sleep is disrupted, if you're not eating very well, if you don't want to get out of bed, if you're not enjoying things. One of the things that we find with our healthcare providers who also don't want giving it but not taking it is that we have the first aid support team, which is people in our profession helping other people in our profession. And that becomes sort of standard. We offer that as part of all of this. So it's not that it's singled out, because the time to talk about well-being and care and the ability to deal with trauma and violence is before it happens, during it happens, and after it happens. And making it on every staff meeting agenda or every conversation with your supervisor helps normalize that. And so the FAST team, regardless of your role, title, or function, you can provide this. And it also works with the person in their coping skills. So like you were saying, some of them need help figuring out what to do with their finances. Well, if that's part of the way they recover, then the FAST team supports them with that. It's not necessarily impinging our values on the person who's been traumatized. Trauma is in the eye of the beholder. And I think that makes all the difference, is that when we're coming at it as a partnership with the person who's experienced it as the expert, then we are a support rather than a judgment.
Okay, but you said about the disturbed sleep. Now, I'm sure that most of my colleagues would consider this as a normal thing. Like when such incidents happen, our sleep is naturally affected.
Yes.
So
sometimes people will experience what I call night terrors, which are panic attacks when you're sleeping. You may wake right up and it's very vivid and it's in color and your heart is pounding and your palms are sweating. That's a sign, a physiological sign that adds to the disrupted sleep. Yes, doctors often don't sleep regular hours anyway. But also if the amount of sleep you don't feel rested either, that's an important component. If you're sleeping more than you used to, that's also a time to be paying attention. So it's changes from your optimal level of functioning that we're looking for. And that can be with your appetite, with your weight, with if you're getting headaches or backaches or stomach upset. All of those are initial signs long before you may even think that you're affected psychologically. You may be affected physiologically. And other people may notice a change in you first before you even notice. And that's what's important, is that we hold up that mirror and say, hey, look, We saw that you went through this. Tell me how that was.
Okay, that's really great. Like, so you really explained like how we should interpret the symptoms. Now, John, as a very expert of the psychological side, I would like to ask you the tips. If my colleague is affected with such problem, how should I help him?
That's an excellent question, and I would say that this also would be like Deborah had described, and actually Dr. Nagpal described as well, that there's the institutions, the Indian Orthopaedic Association, these different professional associations, they should prioritize physician health and wellness programs and health and well-being in the different institutions. They can also make sure that there's a standard institutional response, and then they can train the doctors for that reason. What happens if my peer, my colleague, and does have some struggles? And like Dr. Nagpal had actually described, senior level doctors who could be mentors, who could model how to manage these kinds of challenges. That is so important. And it sounds like the internship training has changed, so there is less of that, which is unfortunate, because that mentorship, that modeling of these kinds of ways to take care of yourself as well as patient care and communication is so important. Nonetheless, though, it's important to learn what are some of the signs that a colleague might need additional support. So if it's known that there was some kind of violent event, and then if you notice that your colleague is showing up late, or is not completing documentation as often, or it seems like not as responsive, like Deborah described, the change in functioning, change in personality, the person smiles less, talks less, then you might pull the person aside in a private kind of setting and ask the person, how are you doing? You went through such a traumatic event. How are you doing? Just a general question. If you'd like me to talk, I'm here to listen. And then as a peer, you don't need to offer advice unless the person specifically asks. You just have to listen, look in the eyes and the appropriate amount of eye contact, and just listen with your arms open, relaxed posture, a gentle tone of voice. And I would just like to listen. How are you doing? You haven't been yourself, and you went through this traumatic event. I'm worried about you. I'm here to listen. Do you want someone who's there to listen? And that might be enough, at least initially, for someone to feel like they're getting support, because the person might be struggling with a lot of painful emotions, thoughts, and might feel ashamed, and might feel like it's going to get better in time, and yet time is passing and it's not getting better. So those would be initial steps to be able to support someone. And then it could be helpful within the institution to know if someone really isn't getting better, what are referral resources where the peer can then say, I would just learned about this resource that might also be helpful for you. What do you think? And so that kind of information could be helpful for the person.
Okay, so we are coming to the end of the webinar. So Dr. Karna and Dr. Nagpal, I will ask you a very tricky question. If Dr. Sivashankar asks you tomorrow that, yes, I really realize that this is a very important topic and we really need to do something. So what will be your tips, or what will be your suggestions you will give it to President of Indian Orthopaedic Association?
So two things. One, there has to be an institutional policy of providing psychological support, whether the person asks for it or not. Unless and until a psychologist or a psychiatrist certifies him okay to practice medicine, he should not be permitted to practice medicine till the time if he has gone through a trauma like this. Number two, when an incident of violence occurs, it should be the responsibility of the head of the institution to file the FIR with the police. Reason is, many cases, in fact, most cases, more than 50% incidents of violence occur against resident doctors. And these resident doctors are coming to institutions for 2 years, 3 years. Somebody may be coming from Kerala to Delhi. Somebody may have come from Assam to Bhopal. Somebody may be from anywhere. And when an incident of violence occurs against them, they are reluctant to get involved in the police complaint because they feel they will be harassed unnecessarily. This responsibility should be the responsibility of the institutional head. And in fact, we have recommended to the to PMO and to the Ministry of Health and Family Welfare and to the Ministry of Law and Justice that a penalty should be prescribed in the Prevention of Violence Act for the head of the institution if he has been intimated of an incident of violence and he does not take action of informing the police or filing an FIR simultaneously. So these are the two things. If you can do this, it will do wonders. Because we have a tendency to take violence and then sit back and not create any deterrent for the next incident.
Yep.
Okay. Yes,
Well,
Dr. Karna, what will be your suggestions
Dr. Niraj Ajpal has told us accurately the situation which is there in the teaching institution. The teaching institution, the situation is different. Rather, the deans and the civil surgeon, they pressurize the resident not to make a complaint or not to make a issue of that. It has happened here. And so that part has to, associations has to tell the deans or those things to take cognizance of this and proceed for the further police actions as well as for the complaints. But as I said, being a nursing home owner, my always stress is on the nursing home owners. For nursing home owners, this particular part, I mean, the situation is little different. There, they have to suffer themselves. And so the association, what can it do? There are 2-3 things. One is the before incidents, the association can have the conferences and the webinars where they can guide them that how to take care before the incidents, and immediately we can have an SOP also, because during the incidents, everything is forgotten. Rather, we always give a chart to our staff that in a given incident, how to behave. That checklist we can give what to do during these incidents. And after the incidents, the doctors are more scared about their defamation rather than actually consequences. So there, if the institution comes forward, but this can be done only by the local institution. It's more powerful. They can meet the police officer, they can meet the other heads, and they can tell them to take a proper police action against these violent makers, so that this will not be repeated. And third part is about the media. There is a bad publicity which is there. The association should come, local association should come forward, because generally this comes in the local newspapers. So they should come forward and either reply to the whatever are the defamation which is there, and they should tell what is there is correct or not. Because there are certain issues which can be solved by the local associations and certain issues which can be solved by the central associations. So especially in the violence, the during and after violence, the role is that of the local association. And before violence, for the doctor's training, it's the role of the central association. That's what I think.
Yeah. So before I ask Dr. Siva Shankar, Dr. Naveen is with us. So Naveen, would you like to give us your views about this? Okay. Naveen probably is busy with something else. Dr. Siva Shankar, what do you think? What is your impression? You have vast experience about this, because as a president, you must have heard a lot of such incidents. So what do you think? How should we move ahead? Sir, you are mute.
See, as Dr. Karna has been telling, the problem is the smaller nursing home. For the information of John and Deborah, we call small, usually one specialty surgeon like Dr. Karna, orthopedic surgeon, running a 15 or 20 bed hospital. So it's because in US, nursing home means old age home. That's why they might be thinking otherwise. Okay. Our problems are entirely different. We are accessible to the people in a factory. The top person is not accessible to the customer. Here, the doctor, the patient asks for the doctor. Unfortunately, in India, the doctors are so easily available 24/7. Many doctors advertise themselves that they are available all the time. They give their telephone number, mobile number freely. So these all things, what happens is the people are not ready to wait even for a single minute. If accident happens, the doctor has to be there immediately. If the patient dies during the accident, nothing happens. But a dying patient brings to the hospital and breathes its last in the hospital, then doctor is held responsible. There are so many things we have to change the whole perception. It's not a one-day job. Everybody is responsible for this. So the bad publicity by the paper, some of the film actors about the doctors, how some of the jokes are created against the doctor. These are all some of the reason we have to blame ourselves also, because even if something happens, our own, it may not be negligent, but loose talking by our hospital staff, giving the information to the relatives, we as doctors not explaining the seriousness to the relatives, not being taught how to handle such situation. They're all the things. And to de-escalate, in Sholapur, we have our local IMA has formed a group. Every year they circulate stickers with about 7 or 8 names. If we inform one of them, if something happens in your hospital, you call one of them. I have put the sticker in next to me and also near the reception. So you just call either the president, secretary, or the medical legal cell members whose numbers are there. They immediately circulate this message to another 15-20 doctors. Within about 5 minutes, we have another 50-30 doctors coming, because when a mob comes in such a huge, we also show our strength. And this has really helped a lot in the last 10 years in so many cases in Sholapur. We were able to diffuse them, because one of them might be known to one of the doctors, or we will recognize one of them. So when they are showing their strength, we should be in a position to show strength. So having the association of a local medical association, local doctors group, everything is very, very important. And loose talking should be totally avoided, because it could be by the doctor himself or any of the staff members. They are the one which sometimes, because they don't give proper information. That's as you were discussing earlier, giving proper information at the right time with right body language is very, very important. Thank you very much. There are many things, but it's yeah.
Yeah.
So
Yeah,
can I
Naveen.
add one more?
Yeah.
In our area, what we have done is that there is one organization of the retired police officers, and we are taking the help of those retired police officers, and they come. We have formed a quick response team, as our president has said. There were 2 response teams. One response team was that of the doctor, which comes from the local organization, and secondly, these retired police officer organization, they are attached to these organizations. And if something goes wrong, those retired police officers, they reach there within 5 minutes, 5 to 10 minutes in that particular area. They are designated certain police officers. And when a police officer comes there, there is a lot of impact on the mob, because they are a recently retired one, and they know how to handle all those people. And sometimes they know those pseudo politicians or the gundas also there. And so this particular action of the quick response team, we call it the QRT, has helped a lot in Pune area and their surrounding districts. That is one more thing we had done.
Okay, thank you.
Even I have heard about some of the major hospital having the people, if you pay them some monthly allowance to them, they have what you call bodybuilders, bouncers. They immediately, if sense something is happening in your hospital, you call that group, the bouncers will come and protect the hospital. Yeah, this is also there in few of the cities.
That is the one eastern part of Pune. It is there. The hospital, they pay 15,000 per year, and they are given this particular service of the bouncers, that they reach there within 5 to 10 minutes. The 3 or 4 bouncers, they reach that hospital and help there. That is another part in the one part of Pune city.
Okay, Naveen, quick comment for you before we end the session.
There is a need for local support group, and there should be some software where the panic button can be pressed by the surgeon himself when there is a problem, and immediately local support group people will come, those who have a good contact with the politicians, press, and the police. That is the only solution in the whole stage.
Exactly. That app has been created by that particular hospital for this bouncers team. Unfortunately, out of the 100 hospitals, only 5 hospitals enrolled for that. That is a bad situation in India. That even when this particular facility is given and the app is also created, you have to just press the button of the app, and 5-10 minutes the bouncers will be there. But still, the apathy of the practicing doctors, that is another angle of the given situation. That why to spend 15,000 per year? This is going to happen once in a blue moon. And why should that much?
No, it's not that. It will not happen to me. The one wrong thing. That is the basic problem.
Yeah.
Okay,
Yes.
thank you very much, everyone. Like at the end, I shall like to give a following comments. The problem of violence against doctor is a multifactorial. Solutions are not that simple. We saw that there is a wide variety of options available for the like solving the problem, but still they are not very simple. But the knowledge that it can be solved, that definitely gives us hope that yes, definitely in future we can do something. But we need to understand that no one doctor can solve the problem alone. Collective efforts are required, and each one of us has to play a unique role to solve this problem. We need to improve our communication skill and learn and adopt the new technique of de-escalation. In addition, medical associations need to create a rapid action force, and I am sure that all of the Indian faculty, they are in favor of that. And really, we need to think in that direction also. So I would just like to say that if our members are really keen to learn more about these techniques, about the de-escalation, how to communicate at the time of death or the complications, definitely we are very happy to carry out a further training. So please share your feedback with the President and the Secretary of Indian Orthopaedic Association, and also give us a feedback like what you like and what we need to do to improve this webinar. So with that, thank you once again, John and Deborah, for sharing your expertise and knowledge with us, and Dr. Nakpal and Dr. Karna, again for we know that you are very busy and Dr. Karna has to go for the next webinar after that. So thank you audience, thank you faculty for joining with us. Wish you a safe time ahead and have a good time with the family. See you soon. Thank you.
Thank you. Thank you, everyone.
Thank you.
Thank you.
Thank you so much.
Yeah.
Thank you.
Thank you all. Thank you all on behalf of IOA. Thank you.
Yeah, Shamsul, you can stop recording now.
Thank you, sir.